A very good afternoon, everyone. I am Dr. Keyur Akbari, a spine fellow from Apollo Hospital, Chennai. Today, I am going to present on the effect of mini-open thoracotomy approach on pulmonary function in Lenke type 1 adolescent idiopathic scoliosis patient treated with novel non-fusion anterior scoliosis correction surgery, also known as the vertebral body tethering, whether it has a detrimental effect or a beneficial effect. My mentor is Dr. Sajan Hegde. You all know that scoliosis is a three-dimensional deformity of the spine, in which there is an alteration of the shape of the chest wall, and it affects the respiratory dynamics as well as the pulmonary volumes and ventilation. So, time-tested, the pulmonary function is a key parameter to identify potential surgical candidates or to evaluate the results of treatment of AIS patient. Posterior fusion, which is currently the gold standard in the surgical treatment of adolescent idiopathic scoliosis surgery. Literature says that there seems to be maintenance of the preoperative pulmonary function values at long-term follow-up, probably 2 to 3 years and even more. But many studies have reported a decline in pulmonary function in the first 3 to 24 months after surgery, which recovers. Concerning to anterior surgery, both the open as well as thoracoscopic techniques have shown to limit the pulmonary function in 3 to 12 months after surgery. But after 2 years from surgery, there are literature which says that the pulmonary function remains same, irrespective of the surgical technique. Our paper deals with that non-fusion anterior scoliosis correction is a fusionless technique which could have positive influence of pulmonary function, as it does not pose limitation to the thoracic movement after surgery, which happens in posterior fusion surgery as well as in anterior fusion surgery. And it maintains the physiological dynamics of the chest wall as compared to fusion, because we are not fusing the spine. We hypothesize that this novel non-fusion anterior scoliosis correction technique through a mini-open thoracotomy approach improves pulmonary function in AIS patients through the added advantage of preserving chest wall dynamics. The aim of our study was to investigate the effect of non-fusion surgery via mini-open thoracotomy approach on pulmonary function in an AIS patient undergoing surgery at 2 years follow-up. This is a prospective cohort study. We had 20 patients included in our initial study, but we had lost 4 patients because they were international patients and we did not have follow-up patients. The minimum follow-up of 2 years. And we included patients only with Lenke type 1 AIS patient with curves between 40 to 80 degree with flexibility 50%, because this is the criteria to include patients to undergo non-fusion surgery. Patients included were 16 because we have 4 lost to follow-up. The mean age was around 13.5 years. We have 15 female patients, 1 male patient. Mean follow-up was around 24.5 months. Mean Sanders and Riser score, they were skeletally mature patients. The radiological measurement, the thoracic corps improved initially from 52, at last follow-up it was 17, and it was significant improvement in correction, as well as even the kyphosis improved. Going to the pulmonary function, we had measured total lung capacity, FEV1, FEC at pre-op baseline, and every 6 months and at 1 year and at 2 year follow-ups. We showed there was improvement at 6 months and 1 year in all the parameters, which remained stable at 2 years follow-up. Respiratory function is thought to be affected by AIS in various aspects. First, the normally AIS patient, the lung development as well as the alveoli development completes by 8 years of age. But majority of the AIS patient will have normal function at the onset of their progressive deformity. It is demonstrated that the chest wall deformity can over time lead to decreased thoracic volume, and more importantly, it affects the dynamic property of inhalation and exhalation, therefore disabling the energy efficient respiration. And in a recent study, which was a meta-analysis on Bailey et al. Stated that anterior fusion did not result in significant change in respiratory function, whereas posterior fusion increased in respiratory function. However, when we do a posterior fusion, we are ankylosing the whole spine, which disturbs the chest dynamics. As a result, the incremental effect on respiratory function can be theoretically and practically negligible in many cases. Our study showed that using this novel technique through mini-open approach and extensively strict incentive spirometry exercises, there was improvement in pulmonary function from baseline.